Good afternoon and welcome to the Alliance for Home Health Quality and Innovations webinar on the role of home health in accountable care organizations. My name is Teresa Lee and I'm the Executive Director of the Alliance. By way of background, the Alliance was founded in 2008 and is dedicated to the mission of leading and supporting research and education on the value that home health care has to offer to patients in the entire U.S. healthcare system. Our webinar today will focus on progress with accountable care organizations, how home health is being used in ACOs, and considerations for partnerships with ACOs. We are very fortunate today to have as our guest speakers David Introcaso and Clif Gaus with the National Association of ACOs. David Introcaso is the Vice President of Policy and Operations at NAACOS. He has had a long career in healthcare delivery, research, and policy in Washington, D.C. His prior experience includes time spent at D.C. General, working in acute care and consulting with the National Hospice and Palliative Care Organization in post-acute care. He has served as the Agency for Healthcare Research and Quality, or AHRQ's, Evaluation Officer, as a public health analyst in the Office of the Assistant Secretary for Planning and Evaluation at HHS. Dr. Introcaso worked on the Hill in the Office of House Majority Leader Steny Hoyer and has consulted with a long list of clients, including the American Heart Association, the American Public Health Association, the National Institute of Nursing Research, and United Health Group. His community work addresses adult literacy, adult survivors of childhood sexual abuse, food banking, midwifery services, and other issues. Among other awards, he was a 4-year Kellogg Foundation National Leadership Fellow, and he's taught as an adjunct at the University of Chicago and the George Washington University. Clif Gaus recently helped found NAACOS and is its current CEO. He also has founded a number of other organizations during his career, including the Georgetown University Health Policy Center, the Association for Health Services Research, now called Academy Health, and Health Reform USA. He has a diverse background as a public servant, entrepreneur, and a health executive. He served in senior health positions under Presidents Nixon, Ford, Carter, and Clinton. In the 70s and 80s, as Associate Administrator of HCFA, now CMS, he directed the development of a broad range of innovations in healthcare financing and delivery, including the DRG Inpatient Hospital Prospective Payment System, RBRVS Physician Payment System, the Medicare Hospice Program, and Medicare Payment of Physician Assistants. From 1994 to 97, he was the administrator of the Agency for Healthcare Policy and Research, now AHRQ, and reported directly to the Secretary of HHS. In addition, in the late 90s, he held the position of Executive Vice President and Chief Administrative Officer of WellPoint Health Networks, which was responsible for all of WellPoint's physician and hospital networks, medical policy, public affairs, human resources, market research, and product branding. Prior to WellPoint, he'd been a senior vice president of the National Kaiser Permanente Health System in Oakland, California. And from 2002 to 2010, he served on the board of the Lucile Packard Children's Hospital at Stanford University. In recent years, he's consulted for a number of prominent organizations, including a 6-month engagement with the CMS administrator working on the ACO regulations and the startup of the Center for Medicare and Medicaid Innovation. We're just so fortunate to have both of these extremely qualified individuals speaking for us today. So, just a few housekeeping notes before we get started. First, David and Clif will speak for approximately 40 minutes, and we'll leave the last 15 minutes to answer questions. Please note that this is a webinar and we control the slides on our end, so don't be surprised if you're not able to flip ahead. Second, all of your lines will be on mute, and you can submit questions to be answered during our Q&A period through the Fuse webinar software on your computers or other devices. And you can send a question to the speaker to be answered in the Q&A period by sending a question to me, Teresa Lee. Finally, we will be posting the slides on the website after this webinar, and we're also recording the webinar, and we'll post the playback on the Alliance's website. Without further ado, I'm going to turn this over to David and Clif.
All right, thank you, Teresa, and welcome everybody. This is Clif Gaus with NAACOS, And NAACOS is very pleased to do this webinar with all of you. We view home health care as a very critical component of accountable care, and look forward to working with you and hearing your input here in the questions and answers period. David Introcaso is going to lead off with a slide presentation. I'll add some commentary, and we'll both be part of the Q&A session. So with that, David, I'm going to hand the microphone over to you.
Thank you, Cliff. This is, again, David Introcaso, and I'll thank Teresa as well for this opportunity to discuss the Medicare Shared Savings ACO program. So with that, let's begin. I'll try to keep my comments actually under the 40 minutes so we can have more time for Q&A. So let's begin. If we can go to the next slide, please, or I believe it would be slide 7. So thank you. So just on background, if you're unaware, this concept of the Accountable Care Organization had its origins in the 90s, attributed largely to Elliot Fisher at Dartmouth. Mark McClellan also, too, had a large role in forwarding or furthering this idea. The provision which authorized the creation of the Medicare Shared Savings Program, as noted here, is Section 3022 in the Affordable Care Act. And you may remember this more from the proposed rule and the final rule. The final rule on the program was published per this date, November 2nd of 2011. And the proposed rule was published earlier that April, and you probably will recall the provider response, because the proposed rule had 60-odd quality measures against which providers would be measured. That caused quite a bit of response within the provider community, and ultimately in the final rule there were 33 measures. There are currently 33 measures. There is a demo component to all this, and those are the Pioneer ACOs. They were created under the Centers for Medicare and Medicaid Innovation, and that's Section 3021. And the Pioneer demo is really the Medicare Shared Savings Program, but a more aggressive version in that the providers can earn a higher % of shared savings, and there are some differences relative to patient beneficiary assignment and some other differences, but it's largely a more aggressive version of the ACO program. And you may know from the recent news, last month the ACO Pioneer demonstration program was quote-unquote certified by CMS. That certification is a provision within Section 3021, and what that means is that the actuary at CMS found that the Pioneer demonstration had demonstrated savings with no deterioration in quality performance, and based on that certification criteria, the actuary certified, and now that means the demo, which was scheduled to conclude next year, is now expanded in scope and duration. You may too be aware that CMS also this past spring, in March, announced the next version of the ACO program, and this called, not too imaginatively termed, the Next Generation ACO demonstration. This was again announced in March. It begins in 2016, and it is still further a more aggressive still variation on this model. Providers can earn up to 80 to 85% in shared savings, and they can take full capitation under this demonstration model. This next generation ACO will have two classes, the first class in 16, the second class in 17. And CMS, because this requires a good deal of capacity and ability on providers' part, they're not expecting more than 15 or 20 ultimately to participate in this next generation ACO demonstration. So that's more or less the landscape. I should say there are any number of pay-for-performance or ACO-like contracts in the commercial space, and we'll get to that in a moment. So there is sort of the flip side of the coin. Commercial payers are doing this or something similar to this as well. So let's go to the next slide. So as noted, NAACOS is the National Association of ACOs. We're a membership organization of approximately 150 Medicare Insured Savings Program ACOs. I will tell you there are 404 total MSSP ACOs. We're governed by the ACO members. They represent ACOs throughout the country. Of course, our goals, not surprisingly, are to try to improve their performance, that being improved quality, lower costs, or the cost growth, and improved population health, obviously analogous to the triple aim. Our work is to work with CMS and the Congress to improve the program, and I'll get to the current proposed rule, which we expect to go final next month in a few minutes. Again, we represent this approximate number of ACOs and Medicare beneficiary lives. You probably know, you may know that most of the ACOs are physician-led, so that's similar for us. And again, we do our work. Our work is supported through our membership, our business partners, our conferences, and other financial support. We conference twice a year. In case you're interested, we go back and forth between D.C. and Baltimore. We'll meet next October, I believe, 8th and 9th. And that meeting will be at the Hilton in D.C. If you go to our website, if you're interested in attending our conference, you could find the upcoming conference materials noted on NAACOS.com's website. Let's go to the next slide, please. So, as I suggested, there are various types or forms of ACOs. You can be basically they break into two categories. You could be hospital-led or physician, either single or multi-specialty practice-led ACOs. ACOs can affiliate with various others, not least of which are home health agencies, so post-acute providers, amongst others. I should note here that currently the program is for Part A and B reimbursement. Part D is yet to be included. Pharmacy benefits are yet to be included under the model, although that's expected sometime in the future. So again, there are various types or kinds of led ACOs, but again, generally it's either physician or hospital-led. Let's go to the next slide, please. So I first titled this slide MSSP, the Medicare Insured Savings Program, Simply Explained. That's very hard to do, so I changed it to Explained Simply. This is a very complicated program. If you look at the final rule in the Federal Register, again, November 2nd, 2011, it's many pages. There are many, many details to how the program functions. So this in 4 bullets is really genuinely just the highlights of how this model works. So Medicare patients are assigned based on preponderance of their utilization. So if a primary care physician saw a patient for most of their care during the benchmark period, they would be assigned to that ACO participating to that ACO participant, because that physician is a participant, obviously, in the ACO. There are 2 steps to assignment. Won't go into all the details. But again, it's really based on preponderance of utilization. The second bullet, ACOs are based on 3 benchmark years. The 3 most immediate previous years are calculated a financial benchmark. It is weighted, so the last year, the most immediate past year is weighted 60%, 2 years previous 30, because obviously the most immediate previous year is the greatest indicator of utilization. So the benchmark is based on 3 years of previous utilization these are average utilization costs for the assigned beneficiary population in 3 categories of Medicare beneficiaries. Again, that's just generally how. So you're assigned a benchmark, and then you ultimately try to spend less than the benchmark for a performance year. And if you spend less, you get to if you're a Tract 1 ACO, you get to share your share of the earned shared savings is 50%. That's the third bullet. You can earn 50% as a Tract 1. If you're Tract 2 ACO, you can earn 60%. But as a Tract 2, then you're at risk, because if you exceed the benchmark, you're responsible for repaying your portion of the overage. So you must, in order to earn shared savings, you must spend less than the performance year benchmark. Shared savings can be reduced by an imperfect quality score. So what that means is if you have a perfect quality score, your multiplier, say you saved $100, to make it simple, your multiplier is 1.0, so you get 100% of your earned shared savings. If you have a quality score that's less than perfect, so it's something less than 1.0, then your share of earned shared savings is reduced by that amount. Patients are not assigned as they are in Medicare Advantage, and this is really where it gets complicated. So patients in any performance year either leave the ACO because in that year the preponderance of their care was provided by a physician outside the ACO, or patients who at the beginning of the performance year were unassigned, but because they received the preponderance of their care by that ACO's physicians during that performance year, they become assigned during reconciliation. So the benchmark more or less floats, and you don't know your true benchmark until after reconciliation. Reconciliation occurs within 9 months after the performance year. So the first performance year was actually 2 years. It was 2012 and 2013. Final reconciliation for performance year 1 ACOs, which were 220 in number, was determined in September of 2013. But again, because patients do not enroll like MA, they can and do see other physicians outside the ACO, so this is the unstable assignment issue, sometimes termed patient churn. This is a substantial problem for the program. We'll get to that, but because the term is used, because it is retrospective assignment, which is you don't know for certain who your patients are until after the performance year, as opposed to prospective assignment. I'll get to that in a moment, the difference. Because it's retrospective, your benchmark can be readjusted, and it is readjusted or recalculated for the performance year based on this churn. And I'll explain further again. But again, basically the way the program works is you have an assigned population, you have an established, and that's the word, established benchmark. You try to spend less than the established benchmark. If you do, you can be rewarded. your percent of earned shared savings. Again, that amount then is multiplied by your quality measure performance benchmark, and that's all determined within 9 months subsequent to the conclusion of the performance year. The performance year, just to say, is the calendar year. So I hope that was clear. Happy to take questions. Let's move on. So the program is growing rapidly. As I mentioned, there are 404 ACOs in the Medicare Shared Savings Program. They represent, you'll see here, 7.8 million Medicare lives in 2015. That compares to 17 million Medicare beneficiaries in the Medicare Advantage program. Both programs are growing, as you can see, year over year quite substantially. So far, in year-over-year growth, ACOs are growing a bit more rapidly. But to give you some comparison, and as you know, the Secretary in February announced they want to move X% of Medicare fee-for-service to some sort of pay-for-value, either quality or performance. And they have percent goals beginning in 2016 at 30%. So they're working towards that, and this growth shows that they'll likely get there. So let's go to the next slide. I did mention there are various types of ACOs. Again, the number is, we note here, 405 ACOs. 400 of them, far and away, the vast majority are in Track 1, and Track 1 again means that technically they're not at risk, which means if they exceed their benchmark, they do not have to repay the difference. However, technically they're not at risk, but in fact they are because, of course, their upfront costs in establishing an ACO, collecting and reporting data, and changing or innovating your clinical practice. 5 are in Track 2. 32 started the Pioneer demonstration. There are currently 19. There are 2 years of performance data for the Pioneer program. I'll get to that. And as I noted, CMS expects about 15 to 20 next year to start under the next generation demo. I did note that there's the flip side of the coin to all this, and that's the commercial side. There are about 340 commercial and both commercial and government ACOs. So we're talking about 740 plus total number of ACOs, 7.8 million again under Medicare, and about 20 million lives total in both Medicare and the commercial side of the ACO model. Again, ACOs vary by type. Again, most of them happen to be physician-led, then hospital, and then there's mixed hospital physician, and there are various others. I should note they're federally qualified health center FQHC's ACOs, they're critical care hospital ACOs, and there's some various others representing a smaller percent of the total. Let's go to the next slide. All right, so here let's go to performance. This is really the rub of it all. Again, we have results to date for just one performance year, and that's, again, the 220 ACOs that started either in 2012 or 2013. So of the 220, 52 earned shared savings, so a little less than a quarter. Actually, it was 58, but 6 of the 58 did not accurately report their quality measures, so even though they earned shared savings, since they didn't accurately report their measures, they could not collect their portion or their percent of shared savings. 12 of the 52 earned about half of all the 300 plus million in shared savings. 119 fell within this is the medical savings rate, the MSR. I'll explain that in a second. 43 were below the negative MSR. So what that means is that you could have saved money, but in order to earn a percent of shared savings, you had to exceed the medical savings rate. That varies. And this is to account for chance, such that if you have a higher MSR, if you have a smaller number of beneficiaries, and you have a lower MSR, if you have a higher number of beneficiaries, this, again, is all to account for statistical randomness, which CMS does not want to reward. So the MSR you have to exceed before you collect any amount. So 119 fell within the MSR, either positive or negative. 53 or below the negative MSR, which meant that they so overspent that they overspent beyond what would have been by chance a negative amount of money that they could have spent, again, by statistical random or chance. Those 43 that were below the negative MSR, had they been in at-risk rather, they would have lost approximately $230 million in sum, which really reinforces why 98% of them are in the Track 1, because they obviously, as I said, it's just upside only. 29 or 59% of the 52 that earned shared savings had quality scores below the mean quality score for all 220. I note because, again, there's a struggle to correlate quality performance with cost efficiency. So this is an indication that we're not there yet. You could have won or earned shared savings, but that didn't mean you had superior quality performance. Now, the Pioneers, this is data for all 32, and again, the Pioneers have 2 years of performance data. Well, not again, but you'll see here in the first bullet, they saved $384 total for the 2 performance years, and it was fairly distributed. 10 saved significantly, 10 saved significantly in only 1 year, and 12 had no significant savings or losses. And then on the quality side for the Pioneers, their scores improved between 12 and 13. But again, what's the relationship between quality and savings is unclear, because there was little relationship as it relates to the 7 CAP scores. There's little relation between high and low CAP scores for those that earned shared savings under the Pioneer demonstration. I could say more about performance, but those are the highlights. Let's go to the next slide. So here's really, I guess, more of the bottom line. What explains the difference between those who earned shared savings or in those who didn't? And here, again, are just highlights. In sum, if you earn shared savings as an ACO, your approximate savings per beneficiary per year, per member per year cost was about 6%. So you saved about 6% off of your per member per year benchmark. And basically the way you did this is you had a change or you altered your referral patterns. And this is what the second bullet suggests. You reduced inpatient admissions, if you were one of the 52, by an average of 9.5%. The reduction for all 220 Performance Year 1 ACOs combined was a reduction of 2.7%. You reduced readmissions by 7%. For all 220 ACOs, they reduced readmissions by just 4.2%, and you could read through the rest. So you'll see home health, for the 52 that earned shared savings, they reduced home health utilization by 5.25%. For the 220 in sum, they increased home health utilization by a positive 1%. Ambulance, the 52 reduced, the 220 increased, and durable medical equipment, you see the numbers, or the percents. For Performance Year 1, the Pioneer Aligned beneficiaries had higher average spending for home health and SNF. So for the Pioneers, despite having higher savings, higher utilization, they saved money because, of course, acute care is more expensive than post. Home health spending averaged 84 cents per beneficiary per month, which was statistically significant, compared to local market, which average had a 0.81, which is to suggest that, again, as I noted, there was a substitution of acute utilization via use of post-acute services. That's what the second bullet argues or suggests. Let's go to the next slide. So the question is naturally begged, if there are ACOs succeeding, although about 25%, and we see a tremendous, so 89 ACOs joined the program in January 2015, so we're still seeing a large number of providers joining the program year over year. So the question is begged, what's the problem? So here we have data that shows, will you stay in the program or you persist in the program? And you could read the numbers here, highly unlikely at 54%. I should note that the ACO contract is for 3 years. So if you join the program in 12 or 13, your 3-year contract is up at the end of this calendar year. So we have 220 ACOs that need to decide sometime in the next several months whether they're going to remain in the program. So about half of the ACOs have to decide in the next few months whether they wanted to stay in the program or not. And there's a good deal of uncertainty or pessimism because of the program rules as they are currently written. So let's go to the next slide and we'll get to this. I did mention that there is a proposed rule out currently. It was published in December. Comments were due February 6th. The proposed rule for the MSSP was about 540-odd pages. CMS suggested a good number of modifications to the program, and here basically are the sort of the leading issues or concerns with the program. Financial incentives are inadequate. Many have argued that the 50% share of earned shared savings is not sufficient. And in addition, if you sign a second contract year, CMS will reset, quote-unquote, your benchmark, and it's based on, again, 3 previous years of performance. So basically what happens if you sign a second contract, you actually have to improve upon your previous 3 years of performance. So basically it's an issue of diminishing returns. So if that's the case, then there ought to be more financial incentives. Patient assignment, there are arguments about how patient assignments can be liberalized, and CMS did propose to include in the assignment process utilization by NPs, PAs, and CNSs such that more Medicare beneficiaries can be assigned to an ACO if they received a preponderance of the utilization of their services via not a physician but an NP, PA, or CNS under a primary care physician within that ACO's supervision. Financial benchmarking, again, as I suggested, needs improvement. There are several ways to do this. I'll just note a few. One is that, and CMS suggested this, one is that you take some portion of the shared savings and you roll that into the new benchmark, whether that's the annual reset benchmark or that's the, updated benchmark, or it's the reset benchmark for a new contract period. So again, this would mitigate the problem of having to chase diminishing returns. There's also a large argument or substantial argument about how do you update the benchmark or trend the benchmark forward. Currently, it's with a national flat dollar amount, and since utilization varies widely regionally, the argument is that the benchmark ought to be updated and reset using a regional update or reset factor, not a national factor. And there are various other suggestions relative to how to improve benchmarking. Payment waivers should serve as incentives. CMS offered in the proposed rule several waivers. One is a home health homebound waiver, and I'll get to that, and I'll get to the other waivers in a moment. But they suggested several payment waivers for which ACOs could apply. If they're awarded the waiver, then the idea being that they could provide better care in a more cost-efficient manner, meaning they could use post-acute services to avoid more expensive acute hospital admissions. Currently, as I noted, patients can go wherever they want. They don't enroll like an MA. So there's this idea that there's some ability to create an affinity such that the churn or the unstable assignment issue I mentioned is mitigated. And so CMS has suggested ideas by way a patient can attest. That doesn't mean they still cannot go to a physician outside the ACO, but that there may be less churn if they attest. And then again, I mentioned quality measures are only punitive. At best, your shared savings just stays the same. It doesn't go down. It can't go up. So as opposed to, say, Medicare Advantage, where you can get rewarded for superior quality performance, that is not the case under the MSSP. Let's go to the next slide. Again, the program is in flux because there's this proposed rule again that we expect to go final in the next approximate 4 weeks. Possible improvements then, I suggested, so inclusion of non-physician clinicians in patient assignment that would increase the number of beneficiaries within an ACO. And again, if you increase the number of beneficiaries, you have a lower medical savings rate. So your MSR hurdle becomes lower to get over to earn shared savings. Regarding incentives, beyond a higher percent of shared savings, as I suggested, as in the Pioneer Next Generation is 80 to 85%, if I didn't note, in shared savings. Changes to the financial benchmarking could provide incentives financially, and the payment waivers. Here I'll mention specifically, so the SNF waiver is the 3-day hospital stay, so that would not be required for a SNF admission. The patient would not have to be homebound to receive a home health services, that the ACO upon hospital discharge can provide a preferred list of post-acute providers, would be limited to providing a preferred list. The patient would still be able to choose their post-acute, but you could suggest to the patient whom you prefer in the post-acute space. That is now not possible. And the telehealth waiver would be based on the originating site, so that the teleservice could be provided without qualifying under the current originating site restrictions. So teleservices could de facto be used more broadly. I did mention allowing the patient to attest such that there's some stickiness, sometimes that's the word used, that is the word used rather, to affirm their participation, so we reduce this churn. The other suggestion I should note, going back to retrospective versus prospective assignment, CMS did suggest a new track, which would be a track 3, and that track would allow a prospective assignment, and what that means is you're assigned a fixed number of patients or beneficiaries at the beginning of the year. You can't have patients churning in under the retrospective assignment like you currently have, but the only way your patient roster changes under prospective assignment is if the patient passes away or they join an MA program, and I think those are the only 2 exceptions. So basically your patient role is fixed. Nobody can churn in. The downside of that under prospective assignment is that your patient could still get, since they're not assigned, since they're not enrolled rather, they still could get care from a non-ACO aligned physician, and you would still be responsible for those utilization costs. But again, the idea is that at least under prospective, you can't have patients churning in. There is the suggestion, and we suggested, that there be greater reward for exceptional quality performance. So if you're, say, in the top quintile of quality performance, whether that's just performance or maybe year-over-year improvement, that maybe you get an additional % of earned shared savings. And this may be an opportunity under the physician fee schedule for 16 because the quality measures in the ACO program are addressed under the physician fee schedule, not in an MSSP proposed rule. There are also improvements suggested for risk adjustment and, again, the medical savings rate, but I'll not go into details. That's more in the weeds. Let's go to the next slide, please. So we have 2 slides here, particular to home health. As you're probably well aware, home health is a concern because it has the largest geographic variation in utilization amongst all types. Even though SNF, we spend more on SNF than we do on home health, there's greater geographic variation of home health spending by region, again by geography. Second point to note here is that you're probably well aware that beginning this past January, CMS started to pay a chronic care management fee. That's approximately $40 for at least 20 minutes per month of services to manage chronic care for qualifying patients, and that's precisely defined. For example, you have to have 2 more conditions. You have to be of significant risk of mortality, and you have to have, the patient has to have a comprehensive care plan. There's some other requirements to qualify to bill for the CCM, but all by way of CMS recognizing the importance of managing chronic care patients more proactively, so they're paying this fee. So this will enable not just ACOs, but post-acutes to be able to bill for ongoing chronic care management. So that's a relevant issue here. Third bullet, I did mention that under the proposed rule, CMS would waive the homebound rule. And the fourth bullet, generally what ACOs are looking for in a home health provider are the following. Their ratings on Home Health Compare, a clean bill of health record, they're accredited, their ability to handle complex cases, use of technology, remote patient monitoring, other asynchronous or synchronous telehealth services, innovative programs for high readmit patients, say, for example, COPD patients, and have 24/7 access or admissions. The last slide, if we go to the last slide, home health agencies can be formally, maybe I buried the lead here, can be formally an ACO participant, meaning they can be a partner in attempting to succeed under the model and earning shared savings. So a home health can be one of a group, a home health agency can be one of a group of so-called provider suppliers, along with, for example, a hospital that is identified by that ACO's participants' tax identification number, so they're formally a member of the ACO. The home health agency would have to enter an agreement to participate, so formally enter an agreement to participate and comply with the shared savings program regulations. That agreement with or among ACO participants, again, possibly including a home health agency, would have to be executed before an ACO submits its application to contract with CMS for the 3-year period. An ACO is required to describe participant rights and obligations in regarding quality, evidence-based practices, etc. And an ACO, currently under the current rules, must not require, as I suggested, under referrals must not require an ACO beneficiary to be referred to one of their ACO, in this case, home health participants. So just because you're a participant in an ACO doesn't mean that, say, those primary care physicians within that same ACO are going to, or even can, refer the patient to that home health agency within the ACO. So again, this slide is to note that you can formally become a participant, which means you then become eligible for a portion of, should the ACO earn shared savings, a portion of whatever that shared savings amount is. So I tried to keep us at our 40 minutes, maybe a little bit under. So with that, I've concluded our formal comments. If Cliff, you want to weigh in, I'm sure you have some comments possibly on clarity. So Cliff, you want to make comment, and then Teresa, maybe we can go to questions.
Thank you, David. Not much to add here. It is a very complex program, and as you might imagine here, as the new model, NextGen, is rolled out with its set of rules that will, in some cases, be considerably different than the MSSP program, there will be much confusion in the industry. We know from the CMS that the NextGen program, which, as David said, is the higher risk, higher reward experimental model, has had a lot of interest, and we believe over 150 ACOs submitted their letters of intent and are in the midst here of the application process. Some of those are pioneers, existing pioneers. Some of those are the MSSP ACOs who are terming this year. Those are ACOs that started in 12 and 13, are up for a new contract starting January 1, 2016. So that roughly 220 of the 400 ACOs are having to make a decision this summer and fall. Do they re-up under the new rules, which we still don't know for sure what they are, in the MSSP program, or should they apply for NextGen? In some cases, ACOs are planning to do both and play both down to the wire in the fall. The NextGen program's rules are not also completely out there. So the ACO community right now is in a little bit of kind of la-la land, maybe, not knowing for sure what the ground rules under either of the new programs are going to be, but knowing that they need to, submit applications for one or both in the next month or two. So that state of uncertainty we're continuing to hear from our members about, obviously, and everybody's anticipating clarity from CMS about both the programs. I think with that, David, let's just turn it over to Teresa and questions.
Great. Thank you guys so much. If there's anything that I'm coming away with, it's just that, this is, when you talk about ACOs, it's really a very complex matter to really understand how it operates and the different rules and approaches. And I guess, we've got one question here that I'll read to you guys, and then I've got maybe a couple of questions too. So, let's see. I think it's the third bullet on the slide 19, the home health agency as an ACO participant. Sort of suggests that home health agencies cannot join existing ACOs. And I guess maybe that's a question. And if there's an ACO that's already in existence, is it possible for a home health agency to join as an ACO participant, or do they have to wait for some kind of reapplication or term change for the home health agency to join?
Excellent question, and Cliff, correct me if I'm wrong, but it is true that before formally starting your 3-year contract, it has to be all worked out in advance, as the bullet suggests. However, on an annual basis, ACOs are allowed to revise their participant lists. And this makes certain sense, of course, because, say, physicians want to drop out, and ACOs should have some flexibility to be able to grow, right? CMS would want physicians to join and not have to wait for every 3 years. In fact, we've argued that the contract period ought to be longer, 5 years. So with that, I haven't ever heard the question asked specifically, explicitly about home health agencies per se, but since you can change your roster, my assumption, therefore, is that a home health agency or could join an ACO within a contract period as an ACO in the beginning of a performance year, as the ACO would modify its list of providers.
Mm-hmm. That's correct, and that's an annual process, although it starts quite early. That list of providers, I think, is due at CMS in the very near future, and CMS then vets those provider suppliers, and it's almost a 4 to 5 month lag between when you apply and when you actually can be brought into an ACO.
Okay.
You know, Teresa, if I can make one comment about performance, which is valuable, I think, and has been widely observed or noted, and that is, and this makes certain sense, those ACOs that have succeeded certainly in performance year 1, and again, this is logical, are those ACOs that are obviously in higher spend per member per year regions. So that's to say, more specifically, if you have a higher benchmark, because in your region utilization is higher, you are more likely to earn shared savings or to beat your benchmark, and to put it more bluntly, because there's probably more overutilization or excess, meaning there's more savings that could be more readily or easily identified.
Right,
So,
and I think that what you're describing too is a similar issue to what we've been hearing about the BPCI program sites as well. That essentially, if you've started out, if your benchmark year is based on utilization that was somewhat high, then it's, in a way, it's easier to be successful because it's easier, there's just more opportunity for squeezing the utilization and finding those opportunities for efficiency that are going to yield savings. And I guess my question is, there's what I think is fascinating. Let me just take a step back. What I think is fascinating is that HHS is sending a very clear signal about their goals, right? You mentioned this during your presentation, that they want to see 30% of fee-for-service Medicare in alternative models of payment and delivery, such as ACOs and bundled payments. So 30% by the end of 2016, and I want to say it was 50% by the end of 2018.
That's correct.
So fairly aggressive goals. I was struck by how, that's a very significant change from the status quo, obviously. So we've got this clear message from the Secretary about where HHS maybe wants to go. And then at the same time, what I'm hearing from you is there's actually a whole lot of anxiety among those who are running the existing ACOs about how to really achieve shared savings and, what changes maybe need to be made in the way these ACOs are operating to really make a viable go of it. So I'm wondering what you guys are thinking about, how to right the ship so that it's viable to have 30 to 50% of fee-for-service Medicare in ACOs without everybody losing their shirt.
Yeah, I think our message has been along those lines to HHS that, look, you have momentum now in terms of organizations jumping into the programs. And if that momentum continues, you'll probably reach your goals. Just look at the trends. However, if you don't fix it, just because people are jumping in, don't equate that with people staying in.
Right.
And the slide that we showed you earlier points out that those that are now in the water are, in some cases, really questioning why they jumped. And certainly, there is enough doubt in it that what's at risk here if CMS doesn't fix some of the program rules are that you're going to see a contraction in the ACO program, and that will absolutely both eliminate the chance of achieving their goals, but I think it'll set the country back a ways in terms of of accountable care and pay per value. So that's why so much is riding on the new rules that should be released here in the next week or two. And we just hope that there are enough improvements that our ACOs stay in the game.
Right, actually, and that actually is the very question that popped up here from the same questioner from before. She's basically asking whether you think the June rulings are going to sway towards helping organizations remain in the program or not.
Well, I will say,
yet. I mean,
per Clif's comment, or pick up on Clif's comment, Teresa, to CMS's credit in the proposed rule, they did propose to extend Track 1s for 3 more years. Now, in the proposed rule in 2011, they're only going to allow you to stay in Track 1 for 2 years. And then in the 3rd year of your first contract, you had to go to risk. So then they said, okay, we'll give you 3 full years. Now they're saying we're going to give you 6 years. So that's to suggest that CMS has a learning curve, and they're realizing this is going to take time. So while I think everybody knows and believes that over time we're going to risk contracting, I mean, Medicare, the commercial payers, et cetera, it's just a matter of how do we get there over what period of time. And that, it appears CMS is going to go final with another 3 years in Track 1, which is a good thing. So they have to enable or allow for time for a learning curve, and it looks like at minimum they'll allow people to stay in. Now, they need to do more than that. They need to improve benchmarking, assignment, et cetera, as we suggested, and we'll see how generous they'll be. But we have some telltales to say that beyond extending Track 1 for 3 more years, they'll make at least incremental movement to improving the model such that people will want to stay and participate, because they know, per Clif's comment, that this has to work.
Right, right. Well, let me just go back to the slide that you shared. It was slide 14 on what explains success or shared savings, because, of course, it's notable that for the ones who are successful, utilization decreased across the board, which I guess is no surprise given that we're really trying to incentivize savings. So that would be something that ACOs are focusing on. But I'm wondering, in your communications with your members who are ACOs, are you hearing from them about what they're trying to focus on in order to achieve those savings? Because it would be difficult, I think, to just sort of across the board just say, okay, we're just going to cut utilization everywhere, right? There must be certain approaches they're using to achieve those savings. So I'm wondering if you can talk a little bit about that.
Yeah, let me try first on this, and then David, you can help too. I think generally speaking, an ACO that is starting out in their first year, after they've gotten their data in place and they start to see the patterns of utilization, are going to go after the low-hanging fruit, and those are the high-cost low-hanging fruit, the high-cost readmissions, and the large amount of unnecessary SNF and LTAC days. And how do they do that? They do that either with nurse navigators that they employ or contract for, or they ramp up and focus their home health care and utilize those staff and those benefits to try to, keep people discharged early, keep them from going back in the SNFs, the LTACs, et cetera. And the ones who I think are successful out there are ones who have either built in-house a very effective, nurse navigator program, or have a contract with a pretty high-performing home health agency. And I think that's the good news for your members here, that you can be really an important part of the success of an ACO. It's a lot easier in markets where the SNFs are overused, the LTACs are overused, there's high readmissions, et cetera. But even in those, in the lower use, lower cost markets, some of those 52 ACOs that had savings came from those markets as well. So it's possible even in the low cost to find more savings, and especially on the acute care and post-acute care SNF and LTAC days.
Yeah, I'd only add to that, and I didn't note this in the slide, that, and you could guess, this imaging utilization was down. So that's not, I think that's an important piece of the pie that should be noted as well. But I'd echo Clif, home health, I'd say in the post-acute space is probably the leading opportunity for ACOs.
It's great to hear you say that, because I do think that, home health as a community, there's sort of this feeling that we're a little bit like the Rodney Dangerfield of the healthcare system, that, we feel like we don't get any respect. There might be some who are younger who don't even know who Rodney Dangerfield, so I'll just say, he used to always say, we don't get any, I can't get no respect, basically. But so that's sort of the feeling, like, we've been, I think that as a community there's this feeling of, how come we're not recognized for what we're doing? And it's exciting to hear that there are more ACOs who are having success that are utilizing, high-value home health, and I think that's very exciting. We're a little over time, but I'm going to ask you one more question. And, you mentioned the Next Generation ACO program, and obviously there's a lot that's not known yet, but, my understanding is that that's kind of getting more towards sort of a global capitation model as opposed to using a historical benchmark. And I guess my question is whether you think that the significant interest that you're seeing among ACOs, the ACOs that have submitted letters of intent, whether that might be an indicator that that sort of more like a global capitation approach is one that might be still more appealing than the shared savings approach that's been used to date.
I think there's a risk here of overhype and over expectation. And what I mean by that is everybody likes to look at something new and think it's the advanced state. And NextGen is the most advanced model when it comes to risk and reward. However, as some of our members have said, it's not for the weak-hearted. There's a huge amount of risk. There's capital requirements, necessary depending on your state, and there is a downside that could bankrupt a normal medical group. So I think the 150 will honed down to probably 50 to 75 applications. More will get ruled out by CMS's data algorithms they run on assignment. And in the end, we'll probably be about where CMS said they'd be, 15 to 20 of these next-generation ACOs, while at the same time, we'll probably have another 100 new MSSPs. The question is, what's the 220 that are terming out going to do? And that's what we just don't know here. So I predict we're going to see some diminution here of the number of ACOs in that 220, and we're going to probably lose 50 or so at least. But that'll be offset by new people in the game with high hopes and some capital to invest. And so I think growth overall will kind of be sustained, but not at the rate we've been seeing it.
I do think it's really challenging, and I think that we're in an environment where we want to be aligning incentives, and that sort of by definition I think means that providers need to learn how to manage risk almost like the payers themselves, and yet we're all sort of new to that. I think that's a very new way of thinking, and whenever there's that significant a change in mindset, it has to be it almost needs to be a little bit bumpy, and there needs to be trial and error. But to me, I think that means that just makes the role of whoever's doing the evaluations of the ACOs just that much more important, because in a way what you need to do is go into the ones that have had some success and see what they were doing, and evaluate it thoroughly and share those experiences so that we can try to keep interest going and perpetuate those practices that have been effective. Is there any further information that you guys are hearing about, more detail around evaluation of the program as it goes on?
Well, L&M is the contractor that has published a few evaluations, so they can be found via the CMS website. So they're available. There's a public use data file with, we would argue, limited amount of data on mostly on the quality measures relative to, again, performance year 1 ACOs. And there's a growing secondary literature looking at, evaluating the program. And I should say that NAACOS has just started an empirical study to look at performance year 1 data to try to improve benchmarking. So it's there's not a lot, but it's growing.
Right. This has been really, really helpful, and I appreciate your generosity in telling us about the program to date and sort of the way your members have been thinking about home health care, and it's just so extremely valuable. So as I mentioned at the top of the hour, we've recorded this webinar, and we'll make sure that we share it on our website for those who missed it, and we'll make sure that we also share the slides. And I just want to thank both of you, David and Clif, for your wonderful presentation and explanation about ACOs today. So thank you, and hope that everybody has a wonderful afternoon.
Thank you.